Welcome to our third video on oral surgery. We're going to start by talking about outpatient oral surgery, and we need to consider what the goals are when we are performing exodontia in particular. So we know we want to achieve profound anesthesia. Of course, we want to separate the crestal gingival fibers with a periosteal elevator, and we would like to elevate and luxate teeth in a generally atraumatic way. Sometimes this also involves the necessity of sectioning teeth in order to make extraction possible. We want to deliver teeth with an appropriate forceps, and this is also going to depend on tooth type and root formation, which we'll take a peek at. Now, there are many indications for extraction that can include gross caries, crown fractures, vertical root fractures, horizontal root fractures, cracked tooth syndrome, and everything up until even orthodontic considerations or aesthetics. So let's jump to the whiteboard and we're going to take a closer look at exodontia. When extracting teeth, also termed exodontia, it's important to have the appropriate instrumentation and armamentarium to get the job done correctly. I encourage you to review this table, which includes a variety of instruments that can be used by oral surgeons and general dental practitioners in order to deliver teeth more effectively. We know that dental providers are not only extracting teeth that are erupted, but they're also faced with impactions as well. We know that third molars are the most commonly impacted teeth, and it's important to know that maxillary canines are only second to third molars in terms of their rates of impaction. So third molars are the most commonly impacted teeth, followed by maxillary canines. Now, why is it a problem to have impacted third molars? Well, first of all, this could lead to decay at the interface between the second and third molars. It can lead to food trapping, periodontal disease, and also even increased risk of jaw fracture in the future. So we know that tooth and its follicle are taking up space, which means that there is less bone in the jaw. And in addition to all of this, we know patients require monitoring to ensure that there are no issues with impacted third molars. So these patients are essentially sentenced to lifelong monitoring, which you as a provider may deem appropriate or you may deem to be inappropriate. So we weigh the risks and benefits before considering extraction of third molars. The same is true with impacted canines, although the stakes tend to be a little bit higher, and of course aesthetics is involved too. So they typically erupt into the oral cavity around the ages of 11 to 12, but when they're impacted, then we need to intervene. So an expose and bond procedure is often performed where a surgeon or a periodontist will expose the impacted canine, and then an orthodontic bracket is bonded to that uncovered tooth and attached to a chain to help facilitate the eruption into the dental arch. So what are some of the indications for third molar exodontia or extraction? We know that malpositioning or insufficient arch space are considerations, in addition to caries, periodontal bone loss, and especially onto the second molar, the adjacent tooth. Increased risks of jaw fractures if we feel like that's a concern. It can also lead us to perform exodontia. And these should ideally be performed between the ages of 18 to 25 because patient healing is superior at that point. And the root formation is generally 2/3 complete. That's when we want to have extractions of third molars, at the 2/3 complete mark. Now, the imaging is known that the Panorex or panoramic radiograph would be the standard of care for third molar exodontia. But CBCT or cone beam computed tomography may also be beneficial. And we need to think about when these third molars might be in contact with vital structures, including the mandibular canal, which houses the inferior alveolar nerve, or when it's near the sinus and there could be other risks involved. So Rude's criteria mentions that there is an increased risk of inferior alveolar nerve damage if any of the following radiographic findings are present. And in some of these cases, you may then want to consider referral to a specialist or CBCT imaging or both. These radiographic findings include darkening of the roots, deflection of the roots, loss of the inferior alveolar nerve canal cortical outline, narrowing of the roots, diversion of the inferior alveolar nerve canal, and also narrowing of the IAN canal. Odontogenic infections may also require oral surgery intervention. We know that grossly carious teeth are often the cause for an odontogenic infection, but there may be other causes as well. So these infections are typically caused by both anaerobic and aerobic bacteria, so it's a mixed infection. That's very common. Oftentimes gram-negative rods and gram-positive cocci are dominating in cultures. Let's take a look at the whiteboard for more details. One of the most important takeaways that you can get from this message is that true resolution of odontogenic infection requires removal of the source of infection, and antibiotics alone are not going to resolve and clear odontogenic infections. You need to remove the source. So imagine someone has a sliver in their finger, or a splinter if that's what you'd like to call it, a splinter or a sliver in your finger, and you just take antibiotics. Maybe it will make it feel better. However, if that splinter remains under the skin, it's going to continuously get reinfected until it's removed. So let's look at the difference between cellulitis and dental abscesses. We know that cellulitis are more in the acute time frame, and they're mainly caused by aerobic bacteria, and there's no purulence or pus. Whereas abscesses require that infection to have festered a bit longer, so a longer duration or time frame is involved. It's more of a mixed aerobic and anaerobic bacterial makeup, and there is purulence or fluid collection present. One of the most concerning and life-threatening odontogenic infections and its manifestation is Ludwig's angina. This is a bilateral infection of the submandibular, sublingual, and submental fascial spaces. And the sources are oftentimes mandibular teeth, of course, mandibular third molars, or teeth that have roots that are extending below or essentially beyond the mylohyoid line. And it's feared that this can lead to airway compromise and respiratory distress. And so it does require a brisk diagnosis and surgical intervention to avoid airway compromise. I think this is likely to be asked on your exam, so I encourage you to review the management as well. In the management of odontogenic infections, the penicillins tend to dominate and are typically the first line. Penicillin itself is usually the first line, and it is bactericidal against most of the organisms involved in odontogenic infections. The next step up would be amoxicillin, which tends to have broader coverage than penicillin and includes more gram-negative species that it is able to impact. Augmentin would then be amoxicillin with clavulanic acid. So augmentin and amoxicillin with clavulanic acid are the same thing. It has coverage that's similar to amoxicillin, but it's also effective against Klebsiella, Staph aureus, Staph epidermidis, and Enterococci. And the clavulanic acid confers coverage against beta-lactamase organisms. We know that antibiotic of choice for odontogenic infections with significant anaerobic bacterial involvement tends to be augmentin. There are also alternatives for those who have a penicillin allergy or when it's necessary to switch the antibiotic. We're going to switch gears now and take a look at mucosal and osseous diseases. We're going to begin by discussing biopsies, and we know that there are high-risk sites in the mouth that we need to be hypervigilant about. That can include the ventral tongue, which is basically the underside of the tongue, the lateral border of the tongue, the floor of the mouth, the soft palate, and the tonsillar fossas. Let's take a look at the whiteboard for details. Indications for biopsy include being suspicious or having a novel finding on an intraoral exam in the form of a new growth, mass, induration, or a tissue change that's not explained by local processes. We know that we should manage this by photographing, monitoring that lesion for 2 weeks, and if there's change, regression, progression, we should note that as well. If the lesion's still present after 2 weeks, without any modification, a biopsy may be indicated. So incisional biopsy is typically recommended when a lesion is greater than 1 centimeter in size. Essentially, removal of the entire lesion or excision may be unnecessary. We need to first figure out what the diagnosis is. So if a patient has a mixed lesion, like something that is erythroleucoplakic, then it's mixed. We want to include some healthy tissue along with the red and white portions of the lesion. We want to be able to show those normal tissue margins for the pathologist to have a comparison. However, for smaller lesions, excisional biopsy may be appropriate, and ideally you want to remove the entire lesion with 2 millimeters of margin into the normal tissue circumferentially. The excisional biopsy is indicated for lesions that are less than 1 centimeter in size, but we can also employ punch biopsies for very small lesions, which are less than 5 millimeters in size. So a tissue punch is used. And then in some cases, a scrape biopsy is also beneficial. Biopsies, however, are not without risk. They depend on the anatomic location of the lesion. So we need to be careful of sublingual caruncles, the lingual nerve, and the deep lingual artery and vein. The opening of Stenson's duct, which is at the parotid papilla, that can be damaged when incising the buccal mucosa in the area of the maxillary second molar. And then, of course, the greater palatine artery and nerve can also be damaged. Biopsy is one reason for tissue removal. However, pre-prosthetic interventions may also be necessary. There's a different reason for the removal of the tissue, but it's also beneficial to the patient. So we're going to take a closer look at this. Pre-prosthetic surgery has the goal of allowing the practitioner to facilitate an ideally fabricated and fitted definitive removable and/or fixed prosthesis. So it allows the restorative treatment to be more effective. This could include tori removal, vestibuloplasty, and frenectomy or frenulectomy. So non-surgical interventions can also be considered. That might include denture relining or flange adjustment or occlusal adjustment, but in some cases we do need to have surgical intervention for effective prostheses. Tori removal might be indicated when it will help improve the fit and adaptation of denture flanges, when tori are large and they occupy the majority of the palatal vault, when there are recurrent mucosal ulcerations, because we know the soft tissue is very thin lying over tori, and when there are significant undercuts, speech impairment, or in some cases, aesthetic concerns. In addition, vestibuloplasty is the deepening of the oral vestibules, and this aids in securing removable prostheses, and it minimizes the lateral displacement and dislodgement. Join me at the whiteboard where we'll talk more about pre-prosthetic surgery and then also implant considerations. The term frenectomy refers to the complete excision of a frenulum. It may be indicated in cases of ankyloglossia, which impacts speech or feeding, and this can manifest as poor weight gain in infants, or when there are high frenum attachments that interfere with oral hygiene or produce a persistent diastema and even gingival recession. And these can also interfere with denture retention. There are many techniques that are involved, but I think that understanding frenectomy at a basic level is going to be critical for your exam. Pre-prosthetic surgery can be helpful in facilitating proper restorations and prosthodontic care for patients. We also know that implants are an important part of today's dental care, especially for patients who have existing edentalism and previously didn't have other options. But we need to know that not all patients are ideal candidates for dental implants. We need to assess patient risk factors, including history of bisphosphonate usage, smoking, and even uncontrolled diabetes, which can impact healing. And then we need to look at the patient's anatomy. Does their maxilla have an over-pneumatized sinus? Perhaps there has been an edentulous site, maybe tooth 3 and 4 have been missing for many years. Now the patient wants to get their implant. What has happened to their sinus? Also, is there sufficient inter-arch space? We need it to be sufficient in order to place implants. And are there bony defects and concavities or thin labial plates? In the mandible, we're worried about vital structures as well, including the inferior alveolar nerve location. We want to identify whether there's knife edge bone remaining, where are the concavities located, and then of course the mental nerve location as well. When patients have a profound anterior loop, there is a much higher chance of paresthesia or other neurosensory damage. And after all of this evaluation, we recognize that not all patients are candidates for the typical simple single-tooth dental implant that they see on television. They may not be a perfect candidate, and that's where cases of zygomatic and pterygoid implants may be considered. Now, this is an advanced technique. Of course, it's indicated when implant placement is not an option in an atrophic maxillary region, and it's not enough to support a traditional endosseous implant. Take a look at that and familiarize yourself with it. That's the end of this video, and I hope you'll join me for the next one, where we're going to be discussing maxillofacial surgery considerations for the general practitioner, where we begin with talking about complications and post-operative management.